Good morning, everyone. Hi, I'm Dr. Waqas Haque, Oncology Fellow at University of Chicago, joined today by a very special guest, Dr. Travis Osterman, who's an oncologist and informatician at Vanderbilt University Medical Center. Thanks so much for joining us today.
Oh, thank you for having me.
Yeah, look forward to having a really interesting conversation about sort of intersection of oncology and health IT. First question off the bat, when I think about fellowship and career options after finishing oncology fellowship, we hear about going to academics, going into industry, going to other kind of fields. I haven't really heard too many oncologists go into informatics. So kind of tell us how you got into that.
Yeah, so my story begins very early on. I've always had a love for both technology and medicine. My goal from, my earliest memories were to get into medical school, but I also loved math all the way through school and in undergrad. I did majors in both computer science and biology. And I didn't have a good plan for how they could integrate them together, but just really was passionate about both of these fields for a very long time. And as I got through medical school and then into residency and certainly into fellowship, there became more and more opportunities to apply those kinds of interests in the healthcare space, and then I became certainly more aware of the field of clinical informatics and bioinformatics and all of the related fields, and just really found my home.
Yeah, no, that's really exciting. And just kind of from relative experience, want to ask just a few quick questions on some brief takes on where kind of oncology is heading with IT
Yeah.
and areas. So first thing, NGS testing, next generation sequencing testing. I feel most oncologists, academic, community are probably ordering it and know about it. What challenges do we still face in terms of access and implementation?
Yeah, it's a great question. So if you look at the ASCO annual meeting for many years, you'll see studies looking at the uptake and appropriateness of testing for next generation sequencing for cancer patients. And here we're talking about somatic testing to guide treatment. Those rates have been much lower than I think many of us would like, but we are seeing those rates increase through work of organizations like NCCN and ASCO to make sure that the testing is a part of their guidelines and standard of care for treatment. My clinical focus is on thoracic malignancies. And so non-small cell lung cancer has, I think, 26 approved drugs that are driven by targets. That number goes up year on year pretty consistently. And so this is a key part of my practice. I think we can do a better job putting systems in place to help ensure that patients don't fall through the cracks, I think is one of them. We understand what a patient's diagnosis is. We largely understand the indications for that testing. And I think we can put some guardrails in place over time to help make sure that practices are testing the right patients. Some of that could be adopting these as quality metrics for like COBE measures. The Quality Oncology Practice Initiative from ASCO. Other things that I think would be really helpful is figuring out data standards for how patients can carry and transfer their own genomic data, whether that's somatic or germline. Right now, we rely on really kind of antiquated systems that are paper-based, and that doesn't allow me to load those into the next electronic health record if I'm a patient with those results. And if it's not loaded into health record in a structured way, I can't fire decision supports and leverage those guardrails, for instance. So I think that those are really some of the opportunities that probably will be addressed in the community over the next 5 years or 10 years.
Yeah, that's actually a really good segue for my next question. I know you do some work with mCODE and chairing a committee for that. Just tell us a little bit about what that means and kind of how we're using AI today to kind of leverage that information.
Yeah, so mCODE stands for minimum Common Oncology Data Elements. This is an international data standard that was really started under the vision of Dr. Monica Bertinelli when she was ASCO president, our former director of NCI, and then NIH later. I was lucky enough to work on this project from really the beginning in the initial working groups. The goal of mCODE, I think, makes sense to any of us that have done research projects in cancer. There are many data standards that come into play when you're using trying to follow the data of a patient with cancer and their journey through their treatment. So you might be able, for instance, to use SNOMED to list their diagnoses, or CPT as a code base to list their procedures that they've had, but almost always there's some gap. And that could be staging That could be their disease status. Are they responding to therapy? And whenever there's a gap, it means that usually someone has to create their own data standard for their project. And then usually that's chart abstraction. Someone has to go and do chart review for that. And that really slows down the progress of discovery. And so Monica's vision, which I certainly share and carry the torch for, is could we create a data standard that doesn't reinvent the wheel, leverages these other existing data standards, codifies them as a group of standards, but also fills in the gaps of what are those spaces that we need to be able to describe a patient with cancer and their treatment journey in the minimal way to be able to make meaningful discoveries in oncology. So this could be on the research side. This could also be for electronic case report forms. So for patients participating in clinical trials, decreasing the burden of staff reporting back to the sponsor or to the investigator how those patients are doing on clinical trial. There's many use cases for this. This is, as I said, an international data standard. So we've been through 4 different ballots with HL7. So we're on what we call STU4, Standard for Trial Use version 4. This is the de facto organization that endorses data standards in the healthcare space. And so we've been incredibly lucky with this. And in 2023, CMS announced mCODE as the standard if you're a practice participating in their enhancing oncology model to submit data to CMS as a part of that program. And so we were the standard that they chose to submit that data electronically. So we were really excited by that, along with all of the other implementations that have been really going on worldwide to help promote this and make the interoperability of cancer a reality.
Yeah, no, that's a really exciting use case. And I think in the clinic directly, I think one of the really obvious and exciting use cases early on, even beyond oncology, is like using scribes for, complex patient conversations, right? Chart generation for notes. And now people are even talking about tumor rate annotations. What are some features you're excited about in terms of applying AI into routine, oncology care in the next couple of years?
Yeah, so this really spans the gamut to things that fix nuts and bolts issues in the clinic now to things that really reach kind of aspirational things. At a busy medical center, we know that right now there's a national radiologist shortage, and the workload of the average radiologist continues to go up year on year. And so being able to support that workforce and protect our patients, I think, is going to be more and more critical going forward. As someone who orders a lot of CT scans to monitor disease status, I always feel better if there's an AI system that's helping us prioritize which studies get read in what order. Meaning, if my patient has an incidentally found PE and they come in short of breath, I would love for my radiologist to read that study ahead of other ambulatory studies because it's been flagged as potentially having a high risk finding. Still gets read by a human. No one's job's being replaced, but it reorders the work so that we're doing it in the right order. So I think that that's very low hanging fruit. We, like many medical centers, have seen adoption of ambient AI. Scribe technology in clinic, where you have a live mic and the system attributes the conversation appropriately between the clinician, the patient, and family members, summarizes that in a format that makes sense clinically, and then allows you to use that as your starting place to edit your note. That, at least at our institution, when we study that here at Vanderbilt, has shown that people really appreciate the time savings. And for some clinicians, it really is the difference between walking out of clinic with your documentation done and walking out of clinic knowing that you're going to have another hour ahead when you get home after dinner to finish your notes for that evening. That's a big quality of life win. And I think that for me, those are some of the most exciting things that are really coming. Those quality of life wins and the safety pieces where AI can really integrate into our systems.
Yeah. And, you kind of mentioned, busy academic medical centers, right? And of course, there's a limited number of them in the country. And of course, 80% of cancer patients might not, get the opportunity or privilege to be in an AMC, but they might be treated in the community. What are some big gaps you see between academia and community care when it comes to health IT or implementation?
Yeah, I think the biggest thing is the resources that we can spend evaluating whether a product is a good fit for us. I have an active role in our health IT group as an associate CMIO, and in the cancer center, I do a lot of vendor evaluations. So I talk to a lot of companies and try to understand what their value proposition is for our patients, largely in the cancer center. I'm supported to do that. Fully understand at small or medium-sized oncology practices, you can't justify, especially taking an oncologist time to talk to all of those vendors and understand what the best opportunity is. This is the other side of the coin. When something is very hot and when there's a lot of opportunity, there are a lot of businesses that are started trying to take advantage of that opportunity. And if you're in a smaller practice, wading through all of those opportunities, all of those businesses and products, and trying to find something that's a good fit for you is a real challenge. And so I think some folks probably tend to implement as many projects as they can. Others probably try to avoid this because of the risk of picking the wrong product. And I think both of those are a real challenge. That's probably the biggest benefit I see right now in being in academics is just having those additional resources to do those evaluations and take advantage of it. I think as the field matures,
Yeah.
I think there'll be some clear winners. I think ambient is a great example of that as a class of products that right now, if I were in a smaller, medium-sized oncology practice, I would absolutely adopt because I think it makes a lot of sense. It allows me to have more face time with my patients. So I think that would make a lot of sense on a return on investment standpoint. But I think many parts of AI are not as developed. So I think it's a lot harder to wade through those.
Yeah, for sure. And I think evaluation is a really interesting point. I know in one large oncology group that I've heard of, over a quarter of the oncologists are above the age of 65, right? So a couple of generations removed from these new AI
Yep.
tools, right? So how do you evaluate? And then even if you implement it, like what percent of them are actually going to make that change in the last 5 years of their career? So it's a good point. What's the biggest challenge you face in kind of your day-to-day job?
Oh, picking what to work on and really doing that value proposition is probably the biggest challenge. There are so many great opportunities right now. I mean, what a wonderful time to practice oncology, and maybe even more so cancer informatics more broadly. There are new technologies and treatments that come out all the time. And again, as I said, sorting through those and figuring out what the best opportunity is. In oncology, oftentimes we're dealing with the better of two bad choices. Here, I think you're trying to pick the best of several good choices, which is a great place to be in. So I think that's probably the biggest challenge is what do we do next and what's going to be the most impactful thing that we can do with our time.
Yeah, definitely. I was just reading an article the other day on multi-targeted agents in oncology. I think half the approvals have in so like whole space have been since 2020, right? So just been an
Yeah.
explosion of all kinds of new therapies. A couple other questions. So of course, not every oncologist is going to want to go through a 2-year informatics fellowship. What advice do you have for oncologists kind of want a little bit more about AI informatics, but don't want to maybe do a whole master's degree?
Yeah, so there's probably 3 formal kind of pathways, I would say nationally, and a kind of a flurry of informal pathways. So formally, clinical informatics is a fellowship through the American Board of Preventive Medicine, and so following any residency, you can apply for that as a fellowship. Now, if you're going into oncology as a fellow, you would have to work that out with both program directors, your clinical informatics program director and your hematology oncology program director. There is a pathway to petition those boards to create a new one-off combined fellowship with terms that you would specify between those boards. So that's one pathway for formal training. There's a set of NLM, National Library of Medicine sponsored research master's degrees. A number of programs nationally have those training programs available for both predoctoral and in our case, postdoctoral candidates. That's for people largely interested in the research of this space. So you could have a clinical practice, but be an NIH kind of sponsored independent investigator with 80% of your time covered on research. Your research will be dry lab focusing on cancer informatics. And that's a pathway, again, at many institutions. There are also programs for applied masters in clinical informatics that tend to be a little bit more flexible to meet the need not of researchers, but of clinicians that are interested in becoming CMIOs, working closely with vendors, et cetera, on more operational questions. And those programs tend to focus on that. So those are at least the formal kinds of programs that you'll tend to see at most larger institutions. And then what I'll say is, the broader aspect of quality improvement, which lots of this falls under, are things I think anyone can work into their practice, whether you're going into private practice or whether you're going into academics. Largely, I think about the work that I do as creating and fixing systems and trying to make systems work better. It's the thing that motivates me to do a little bit less clinical time, because if I can make the system work better for my colleagues, by in part, I hope then that they can see and affect the lives of more patients. And in that ends up being a bigger value. So that's been my goal. And I will say that here you'll hear us talk a lot about people, process, and technology is only one part of that triangle. So understanding people and process is our other keys, I think, to being successful here. And I would argue that coming through medicine allows you training in a lot of those other two areas. The technology piece in many ways is the easier piece. It's much easier, I would argue, to be a physician and try to learn the technology, which largely there's a lot of resources available online, than to be non-clinical and try to learn the clinical aspects of training online. I think that's getting easier, but still probably a harder path.
Yeah, no, definitely agreed on that. And kind of, last question and kind of transition from what you mentioned about, what a doctor can and can't learn or versus non-doctor. I know you do some coaching services for physicians in academic medicine. Kind of tell us a little bit about that and kind of what you're working on there.
Yeah, this is just a really natural extension of things that have come up over the years. So I've tended to volunteer for ASCO's mentoring program. We meet at the annual meeting and usually get a chance to talk with residents or even students, oftentimes fellows. And we've had growing numbers of people that are interested in going into some combination of IT and cancer. We don't have great mentorship at a lot of places because this is a very niche field. And so I started a small company, facultycoaching.com, to just help fill that void. If you're at a program that doesn't have great mentorship, but you have a passion for this area, I'm happy to engage and do what I can to support the career development of our junior faculty members that are interested in this.
Yeah, thanks for your service in ASCO and for your working on. That's really cool. Yeah, thanks so much for your time. Really appreciate it. Had a really good conversation and yeah,
Yeah.
all the best with everything you're working on.
All right. Well, thank you again for inviting me, and anyone feel free to reach out to me on any of the social platforms.
Awesome.